Don't have a voice.
Hi, everybody. Glad everybody's here. You know, people are still signing in and the numbers are climbing up, so that's great. So I'm just gonna give it a couple of minutes more to let everybody in, and then we'll get started. Oh, look, people are chatting in their names in the box. That's fantastic. That's just what we want to hear. See? Just like last time, more people in the chat box, please. Please write your name and your home.
Hello, madam. How are you?
Good. Good. Okay. Oh, look, we got more and more people signing in. That's fantastic. Great. Okay, everybody. So you can keep on typing in there while I'm talking, but this is Dr. Wen. I'm a geriatrician with the Department of Geriatric Medicine at JAPSOM. I'm the course director for this care home series. And our purpose is to help you deliver the best care for our kupuna living in our care homes and family foster homes or foster family homes. So
Nice to hear you again, Dr. Win.
Yay, I know. You're such a good crowd. I really love teaching you all.
And we appreciated it.
Oh, thank you. All right, so let's see. Next slide. Let's see. What is ECHO, right? Everybody should know by now. This is a model of online education, right? That is not just lectures. It's a forum where you, all of you, and me can learn from each other, share our experiences, and provide a safe place to ask questions and talk about what you see every day. And it's okay. You can stump us, and we can all try to come up with solutions all together. The motto for ECHO is all teach, all learn. And so our purpose here also is to create a community of learning. And so this ECHO thing is free, right? That's another really good thing about this. Free continuing education credits. It's free, it's convenient, and you don't have to leave your home or your clients. And after a short lecture, we share expertise and we invite you to answer questions. And actually, this time I'm going to be asking you questions in the middle of the lecture too. So really want you to be interactive here because, we're going to talk about dementia behaviors, right? And that is definitely, I think, going to be interactive. Next slide. So a couple of ground rules. We have to keep patient confidentiality. That's what we call Hipaa Compliance. So no personal identifying information, but we can talk about our patients that we need to without mentioning their names or anything like that. This should be a safe place to learn and share, but also note that this is not a doctor's consultation visit, and the purpose of the series is really to provide a forum for learning and sharing. Next slide. So a couple of Zoom logistics. If you haven't figured it out by now, there's a chat box at the bottom of the screen. Enter your name and everybody else who's joining the session in the same room with you, looking at the same screen, because that way we can keep track of your attendance, right? So we can provide you with continuing education credits. And let's see. Oh, and then there's a mute button also on the bottom. And when you are not speaking, we ask you to put the mute button on so we don't hear all this extra noises in the background. But you can click it again to unmute if you want to speak. And in fact, we want you to speak. So we want to encourage that. This is the ECHO schedule of the month. You've actually covered. Next slide. Yeah, that's correct. Today is June 17th, and we're going to be talking about managing a dementia behavior crisis. And then next month, we'll continue with dementia behaviors, but talking about preventing dementia behavior crises, right? All right, so next slide. And regarding continuing education credits, doctors who join us can get CME credits, and it's sponsored by the HCCME. Nurses can also claim continuing education credits, and social workers can also get social work credits. And all others, if you're not an RNMD or a social work, you can get certificates of attendance. So when you go onto the evaluation page online and you click that link over there, which will be in the chat box later, just select certificate of attendance when you are filling out the evaluation. Okay, and in terms of, I just want to introduce everybody to the team here, if you don't already know, and I'm sure you know everybody here, is we actually have Juanette here as well. And Juanette, you can say hello.
Aloha.
Yes, thank you so much. And Maribel, are you here?
Yes, Dr. Wen. Aloha,
Yeah.
everyone.
Great, thanks. And Juliana?
Hi, everybody. Thanks so much for joining today.
And we have Shane Anderson.
Aloha, good afternoon.
Okay, you made it as well. Awesome. So we got the whole team here. And we're going to start off with the first slide, and we're going to talk about our Dementia behavior. So John, if you could put up the slides for today's deck, that would be great. And just give me 1 second. I'm going to go offline for 1 second, and then I'll be right back. Sorry. Hi there. Sorry about that. Okay, so let's get started. Okay, so let's see. So you see this? When you think of dementia behavior crisis, what do you think about? Do you think about combat? You think about kung fu, martial arts, skill, agility, strength? What do you need to handle all this behavior, right? Some of these guys are pretty strong, right? So actually, what we're going to talk about is that you do need some skill, and you do need some flexibility. But let's talk about that a little bit and see, what do we really need to do this? Okay, next slide. Okay, so we're going to start off with a case. I bet you'll find this a little familiar. Miss Laura Lolo, this is not a real person. We made up this person. Miss Lolo is a 78-year-old female who had a fall and a hip fracture 4 weeks ago. She had surgery, and after 3 weeks of rehab, she was transferred to your care home on Thursday. It's Saturday now, 2 days later, when you tell her, take her meds, and she tells you it's poison. She throws her glass of water at you, and when you try to explain, she demands to be let out of this prison and threatens to call the police. She has been eating less for a few days, and she refused breakfast this morning because she wanted to sleep. She had difficulty answering questions, which is not like her. Has anybody seen anything like this before? I would think, yeah? All right. Next slide. So what are we going to do today? We're going to talk about, these are the learning jets. We're going to learn about recognizing delirium and recognizing psychosis. We're going to learn about how to describe the behaviors accurately, consider some underlying causes, things to think about first, and then assessing for other triggers, and then we'll do something about it. So what do you do with basic crisis intervention? And maybe try some helpful communication approaches. Next slide. Okay, so first, recognizing delirium and recognizing psychosis. So next slide. What is delirium? So delirium is a sudden disturbance in the state of mind due to medical illness or intoxication. So basically, your mind goes low, right? Suddenly, all of a sudden, out of the blue, due to something. Next slide. So how do we recognize delirium? Delirium, the big thing that I want to emphasize here is the sudden onset of new behavior. So for her, it's new in the past 2 days. She was not like this before, right? Other things that you notice at delirium is that people have trouble paying attention. They get distracted easily. They're confused, disoriented, and they're doing crazy talk, right? And they have something what we call psychosis. Psychosis is the medical term for like when you see things that aren't there, hear things that aren't there, or believe something that's not true. So for example, this person is thinking, somebody should watch the children. There's no children there, Oh, there are bugs in my food. Maybe he's seeing something in the food that's not really there, right? Or believing things that aren't true, that's delusion, such as the ladies are plotting against me, or there's poison in my drink. See? So these first two are like hallucinations where you see or hear things that aren't there, and delusions are when you believe something that's not true. Also, what you may see is agitation and restlessness. And other things that you might see are they may be unusually sleepy, or they may mix up the day and night. So they're awake at night when everyone's sleeping, or they're sleeping all day long when it's time to eat, right? So these are some of the features that you see when we are thinking about delirium. Next slide. Why is it important to recognize delirium? Because delirium is often due to a lot of medical causes. So we need to address the medical causes in order to reverse the delirium. So some of the most common causes for delirium is a change of medication. Maybe they didn't tolerate the medication. So one of the things you might ask is, are there any recent medication changes? Did they just come back from the hospital and start a new antibiotic or start a new pain medicine? Something's going on. Maybe the medicine is not working with them very well, right? They're having some side effects. Another important cause for delirium that's very common is an infection. Sometimes people may develop a fever, cough, diarrhea, or pain, or frequency, going to shishi too many times, too often, right? Those are possibilities of infection, and infection needs to be treated. Otherwise, it's life-threatening, right? Sometimes it's dehydration. If they're drinking not enough and their blood pressures are dropping, that's another cause for delirium. Or low oxygen. If they're short of breath, if their lungs have fluid inside of them, too much fluid overload, it can also cause delirium. Severe pain could cause delirium. So even if they may not tell you, maybe you have to look. Did they fall recently? Have they had some recent injury, that they're not telling you about it? Or, maybe they have some abnormal labs, maybe some recent changes in their medical condition, and that threw their labs out of whack. Maybe their blood counts are too high or too low, something like that. And so that's why it's important to think about how we need to get to the bottom of this, because they have a medical emergency, actually. That's why it's important to figure out if they have delirium. Next slide. So that's right. So if you think they might have delirium, you see all those features, you have to get them to see the doctor. The doctor will look for the underlying medical problems. They're going to do a physical exam, probably get some lab tests, maybe check a chest x-ray, get a urine sample, look at the medications, maybe discontinue some medications that can worsen brain function, or change the medication from one antibiotic to another one that's causes less confusion. So we have to treat the underlying condition. Next slide. Okay, assessment. So when you call the doctor, you have to be able to describe the behaviors accurately, right? So in order to get the proper help. Next slide. Yeah, so you know, just saying, "Oh, doc, patient is agitated," is not quite as helpful. But let's describe it a little bit. Like, what do you mean? What's going on here? And so, you know, if you can describe it, then we can always follow up with it later to see if that specific behavior has improved. So sometimes, you know, it's verbal agitation. That is the things that they say. They're very aggressive, like they're screaming or cursing or verbally abusive and calling you names. Or perhaps it's not aggressive and they're just anxious and irritable. Help, 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 help. Come, I need help, right? Or repetitive questions and they ask over and over and over again, right? That's different from being aggressive, right? And calling people names. Next slide. And even another really important distinction is the physical. I mean, are they just pacing and tapping and banging or just having sleep problems or restless? Or are they aggressive, grabbing, throwing, biting, and hitting, right? Those are other aggressive physical behaviors. It's important to know that because actually, if you tap the slide again, John, if it's you see, I circle that because if you're describing it's aggressive physical behavior, that's a whole other category in and of itself, and we have to really be careful about getting hurt and needing to prevent getting hurt. Okay, another really important thing is to describe the frequency. You know, sometimes these behaviors, how frequent is it? Is it less than once a week, twice or several times a week, once or twice a day, several times a day, or several times an hour? Or they're constantly nonstop, continuous screaming, you know? So being able to describe the frequency, because if we do an intervention, we try to treat something, we need to see, oh, maybe it's getting better. We can tell it's getting better because it's happening less frequently or less severe. Next slide. The other thing we have to consider is what are other behavior triggers? So what are these behaviors? One way to look at these behaviors is that it's communication of unmet needs. When folks are confused or have dementia and they cannot find the words and they cannot cope with challenges, they're unable to, they don't know how to communicate, and so they just have these behaviors because they're trying to tell you something that they can't put into words. So communication of unmet needs. So that's what we need to think about. Next slide. And the other thing to think about is that behaviors can also be a response to feeling unsafe. You see this cat here? If this cat has an injury, say if it has a cut on its belly or something like that, it's not going to let you near him. If you try to reach your hand out to touch say pet the cat, hey kitty, kitty, you know, and do something, they're going to take their claws and they're going to scratch you, right? And they're going to get mad because they don't want to get hurt. They feel unsafe. And this is something people have termed trauma-informed care. It's by assuming when people are having these behaviors, maybe they've had trauma and they feel like this situation is dangerous. So they feel helpless and traumatized, right? And so that's the reason why they lash out. So really, we're caregivers, right? We don't intend to traumatize anybody, but sometimes we can trigger or re-traumatize people by saying or doing things that can make them feel unsafe. And not that we mean to, but we need to think about it from their point of view. Does this make them feel unsafe? Next slide. So we have to be a detective, right? We have to look for this unmet needs and look for this potential, what's making them feel unsafe. So this is a paradigm. Some of you may have seen this before, but it's always worth repeating. Think of the hierarchy of human needs. This is a Maslow hierarchy. And so basic needs include, you have to start off with the physical needs, then safety needs, love, belonging, and respect, and then having a meaningful life. So we have to pay attention. And then when we look at each need, we have to ask who, what, when, where, why, and how. And I'll describe that a little more in the coming slides. So next slide. Okay. Actually, I'm not going to describe that in the coming slides. I'm going to discuss that in the next talk. However, we're going to learn some basic skills here. So let's see what we've learned, okay? So I need you guys to chat in the chat box or unmute yourself and, tell me what you think. So this is your turn. Does Miss Lolo have delirium based on what I explained to you earlier, right? So I just want to show you also, you see this tool, it's called the Stop and Watch tool, early warning tool. I don't know if some of you may have seen this before. If some of you have worked in a nursing home before, a lot of nursing homes use this Stop and Watch tool, and it's very, very helpful. But basically, if you find something that has changed while you're caring for the resident, those are things you need to take note of and take it to the nurse or the doctor and let them know that these are the specific things that have changed. That Stop and Watch seems different than usual, or talks or communicates less, overall needs more help, or they have pain, either new or worsening, or participated less in activities. And it's ate less. N is no bowel movement. D is drank less. W has a weight change. A is agitated or more nervous. T is tired, weak, confused, or drowsy. C is change in skin color or condition. And H needing more help than usual. So let's take a look at this. Does Miss Lolo have delirium? What do you think? I'm looking for people to put something in the chat box or to unmute yourself and just say one or two words. What do you think? Does this person have delirium?
There's some responses coming in the chat box, and it seems like everyone is saying yes. Would seem so.
Great. Yes. Do we have, what do you see in this case that tells you that she has delirium? What do you see? What's the big clue here? Post-op, yes. Post-op, right? What else? Oh, saying that medicine is poison. That's the solutions, right? Poison, prison, unusual behavior. Yes, good. What else is telling you that there's delirium? What else is telling you? Oh, yes. Sudden onset, eating less. Uh-huh. You guys are good. Oh, anger, throwing water, yes. Delusional thinking. Atypical behavior, yeah, this is not what she usually does, right? It's not like her. Unusual. Okay, yes. Okay, next slide, please. Great. And so, yeah, you've got all the answers, right? I circled the boxes, right? 2 days later, that means it's sudden onset. It's poison. Let out of this prison, please, She wanted to sleep. Remember, we talked about how day-night sleep can be mixed up, awake during the night, sleeping at daytime, and difficulty answering questions, right? Trouble with concentration. That's not like her. Right. That's right. Okay. All right.
I think in the chat box, they also said there was also a hip fracture and not likely to use the toilet easily.
Mm-hmm. Yeah. Okay, lots of reasons for her to have delirium. So what are the other triggers? What else got her going here? Anybody else? What else got her going here? Was there anything about the approach? Oh, mood swings, yeah. Next slide. Oh, tell her to take them, not a warm approach. Yes, commanding to take the meds. No relationship. That's right. Yeah, that's right. So you got the answers, right? You were telling her to take her meds. You didn't ask her nicely or anything, right? Probably just walked in and said, shove them in front of her face, here, take the meds, right? And you think reasoning with her is going to help? You guys know it doesn't, right? You try to reason with someone who's delirious, it doesn't work, right? And she was trying to do that. So, crisis intervention. First step is she a danger to herself and to others? That's the first question, right? Also, people have to realize that patients have an urgent need to feel safe. And agitation, that behavior is she's trying to protect herself, right? She really feels threatened for some reason, and she's trying to protect herself. That's why she's not taking the meds, and she's trying to push you away. She's not trying to hate you. She's protecting herself. So first, we have to control the danger sufficiently and then allow time for watchful waiting or cooling off. Right? Okay, and then listen. Creating safety, listening without judgment. You see this kitty cat? She's very soft and cuddly, right? And she's upside down. She's ready to have you pet her, right? Because you're not dangerous, right? You're just nice. You listen and you're like sweet and you agree with them for everything. You empathize with them. Oh, I see, having a hard time, right? You whatever they complain about, you go, oh yeah, I can see why you could feel that way. Don't dismiss their concerns. And create a place of physical and emotional safety, right? So that means you have to show respect and be supportive, just show that you care, and the cat won't scratch you, right? They will maybe let you pet them, right? Next slide. Okay, so the next steps, right, for crisis intervention is just to realize that intervention to a person reinforces helplessness. You're doing something to them. But intervention, doing something that's patient-centered or strength-based, honors the individual. Okay, so that means you go with whatever they you tell them that they're very smart and they're very understanding and you're really good, and I don't know, just talk about things that you're very concerned about your health. I can see that. So something to appeal to who they are, their strengths. You know, if they were a former nurse or if they were a former social worker or a caregiver, right? You can sort of work with that. And you work intervention with somebody. That is, you promote engagement and partnership. So if you find some way to be a partner with them, right? Develop a relationship and to be a partner, then that can go a long way. So that's the spin you got to take. And you got to take care of the whole person because there might be multiple needs, not just one thing, right? And realize that mental health crises are temporary, right? When you are stressed, usually that passes after a little while. Once the stressor is gone, right? It doesn't define them. It doesn't mean that they are always going to be mean and nasty and lashing out, right? That's just right now because they're trying to protect themselves in this very crisis situation. I bet we all behave differently during crises, right? Okay, next slide. And so the other thought I know people have is, oh, medications, we need to get some Ativan in here, right? Or something like that. What about behavior medications? Actually, so I'm telling you as a doctor that behavior medications are not ideal. They don't actually help much, except maybe to make them sleepy. That's pretty much what all they do. And a lot of these behavior medications have bad side effects, right? When you give them the medicine, they get sleepy. Guess what? You increase the risk for falling. Would you like to trade the behavior with a fall? Which is worse? You know, that's bad, right? These medications, these antipsychotics can also cause stroke or movement disorders like shaking and tremors or weight gain if you take them all the time, right? So it's not that simple. And a lot of these medications won't take care of the underlying problem, right? So really need to try these non-medication and supportive strategies first. Once in a while, these medications might be justified, though, if they have hallucinations or delusions or very severe agitation that could hurt themselves or hurt others. So only when it's really severe and it's causing a lot of distress, that's when it's warranted. But we always try the non-medication and supportive strategies first. Next slide. Okay, now it's your turn, right? So what do we say to Miss Lolo now that she's already kicked you out of the room? Is anybody looking to go back in there and try again, or what are you gonna do this time around? I'm gonna see if we can get any good experiences out there that you can share. Are there things that you wouldn't do? Give her space. Reassure her that you are there to help. Don't tell her she's wrong. Wait for a while, and then when you go back, make sure to approach her nicely. Go back in 10 minutes, give her time. Yeah, I've definitely seen people keep on insisting, and that never goes well, right? Leave her for now and give her space. Reorient her after a few minutes and change your approach. Yes. Yeah, so yeah, basically, and what would you tell her actually if you went back in a few minutes later, 10 minutes later? What's some things you might say? Oh, look, walk back in with a smile. Ask her how's her day. Right. Usually people with delirium don't have a great memory. They're not going to remember 10 minutes ago you came in there, right? So they might think you're coming in fresh. Warm and nice greeting. Good. What else? What else? People have seen this, right? You've done this, right? Nice. Next slide. Right? So you hit it on the head, right? You hit the nail on the head. Don't tell her to take her meds. Ask her nicely, right? And don't argue with her. Just agree, right? There's no point arguing. Try backing off. And you might have to send somebody else in, because if she recognizes you and doesn't like you, yeah, it might not work, right? You could try send somebody else in, right? And like somebody said, right? Warm and nice with a smile. Approach her gently. You can greet her at the doorway, wave and smile, tell them who you are. May I come in, please? Get permission. Ask her, you didn't eat breakfast this morning? Is everything okay? Are you feeling unwell? Is there anything I can do to help you be more comfortable? Would it be okay if I checked your vital signs and make sure you're not sick? Oh, yeah. Have the family call her and get her in a good mood. That's good. Distraction is good too. That's right. Offer ice cream. Oh, with the meds. Ice cream works, yeah? What else? Yeah, in fact, if you've decided already from that first encounter that she has delirium, you know that you're going to be calling the doctor, right? You're going to be calling the doctor. And what do you think the doctor's going to want to know? Her vital signs, right? Probably. So, yeah, so trying to get her to take her meds and maybe in a nice way, try to get a couple of vital signs on her while you're at it and talking story and distracting her with something else. Those are all good. Gotta do it while you can. And maybe go with somebody else if need be, right? Get a urine sample if you can, right? You gotta get it while you can, right? Because if you try to go in later, she might change her mind again, right? Right. Right. Okay. Next slide. Yeah, you guys are good. So when to get help? If the patient is not in immediate danger, but you believe they have delirium, you should call the doctor that day and you should get them to a medical evaluation that day. Don't schedule it for next week. They need to do, if the doctor won't see them, at least if they can get urine sample, vital signs, maybe some blood work, and then eventually get to see the doctor later that day or go to urgent care. But as I said, most delirium is due to a medical problem and it's a sudden onset. It needs to be addressed. Otherwise, whatever the underlying problem is may get worse, right? And that puts them at danger. When else do we get help? Well, if the patient is in danger of hurting themselves or others, then yeah, I mean, if they're throwing TVs at you, that's bad. Call 911. But you should know that there's actually not a lot of Jerry psych beds out there, right? In fact, I think Hawaii doesn't have any. They will probably not get admitted. So even if you sent them to the emergency room, they may not solve the problem too much. They may be able to work up the delirium, but they're probably going to send them back to you after they work up the delirium, get the labs and the x-ray and the urine. So ultimately, the change in approach is still the most effective intervention. So if they get the medical evaluation, they still may come back home to you, and that you still have to figure out how do we approach this patient to manage the behavior, right? Just relying on medication to make them sleepy is not the plan. Yeah. Next slide. Okay, so I just wanted to leave you with a couple of final thoughts, and then we'll open it up for case discussion, because I'm sure you guys have cases that are challenging that you've seen. And I just, this is, as I talked about before at the first slide, right? You think this is, what do you need to manage dementia behaviors? Do you need to know Kung Fu skills? Well, Bruce Lee, right? He said, he's the Kung Fu master, right? He's done a ton of Kung Fu films. He said, notice that the stiffest tree is the most easily cracked, while the bamboo or the willow survives by bending in the wind, right? So if you want to be able to manage these very difficult behavior crises and dementia behaviors, you have to be flexible, you have to be skilled, and you have to be able to navigate. You got to go with the flow. If they push, don't resist, go with them, agree with them, redirect them, come back around, and approach it again from another angle and dance around them until you can get them to cooperate. So it is a little bit like Kung Fu, and you have to be highly skilled. So I'm going to leave you with that thought, and then I'm just going to open up the floor for discussion. So people have challenging cases they want to talk about, then I'm happy to, and I'm sure that I see there's other folks here that can probably answer these questions as well. We'd love to hear your stories. What kind of stuff are you seeing in your homes?
Can you hear me?
Yes.
Oh, okay, well, I do. I have one resident that is delusional and he also hallucinates. So basically, he was on carbidopa four times a day. And we actually just recently, maybe about a month ago, decreased it to twice a day. So we tapered it down and he's actually much better.
Mhm.
So that's a learning experience.
Yes. So yeah, sometimes it's the in fact, it's one of the most common causes for delirium. It's medications. Good learning point, right? So it's always good to take it to the doctor and have them check it out. Oh, I have here.
There's a question in the chat box. What if Miss Lolo's behavior is triggered by a caregiver's presence? And if we leave her alone, she might fall. What should we do?
I'm going to throw that out to the audience a little bit and see what some of the thoughts are from your colleagues. Have you dealt with that? Right? Sometimes it is you, right? They don't like you. And then they like somebody else. Here, keep your distance, but keep in safe and close keep your eye on her, right? Before you leave, make sure you're safe and close contact. Have your substitute stay with her instead of you and get another person involved. Yeah, sometimes you can't take it personally, but maybe you remind them of somebody that they really hated when they were a kid. I don't know, right? Sometimes it's funny. They think, oh, I know you from somewhere. You do? How do you know me? You look just like so-and-so. Like, oh my. Change the approach. And the other thing is, if they're going to be unsafe, remember we talked about if it's a really big crisis situation, you have to find a way to let things simmer down, but keep the danger away. So, if they're throwing, silverware, you got to remove the silverware, right? Or glasses or something like that. If they're going to climb out of bed and fall, maybe you need to put a mat on the floor before you go away, right? Oh, look at this. A bed alarm. That's right. Facial expressions.
There was a question in here. Could you please elaborate more on different approaches and redirection techniques? It's a practice that needs different styles because if only one approach will eventually lose effectiveness. Thank you.
Yeah. So we're going to talk about that next week, but we could talk about it this week too, and then we can reinforce it next week. But yeah, one style doesn't fit all, right? Like one size doesn't fit all, and everybody's a little bit different. And so some people respond to music more than others. Other people respond to pets, right? Other people respond to, look, introduce a pet, right? For emotional support. Other people, maybe a stuffed animal or a very soft pillow or blanket would help them feel more secure, right? So the thing is, that's why we go down that, remember that pyramid picture that I had earlier? And I said, you have to be a detective. You have to go down that whole pyramid, go up that whole pyramid and think, okay, what is it that's making them feel unsafe? You know, do they have basic needs that aren't met? Are they maybe, you know, sometimes ice cream solves everything, right? Or give them a cookie. Uh, like kids, right? If they're throwing a temper tantrum and, you know, maybe they just didn't get their snack and they're kind of hungry. They just didn't know how to express that, right? Or maybe, so some basic needs, you have to make sure they're not having hungry, thirsty, too hot, too cold, pain, things like that. And then think about safety. Is the environment overstimulating, right? If it's overstimulating, then you just need to get them into a quiet place. Make sure that if the somebody in the other room, there's too much noise going on, then we have to get away from the noise. You know, let's go outside. It's too noisy here. We need more quiet. You cannot get out, then maybe put music on that's more like a headphones, you know, or something like that, where you can insulate them from the outside banging if the whatever construction worker is here or something like that, right? So
There's a question in the chat box regarding baby monitors. Is a baby camera monitor okay to install if there are cases that patient doesn't want a caregiver on a certain time or a certain situation?
I don't see why not. As long as it's okay with the family, you know, I don't think it presents I think it's more for safety. Oh, look, somebody's very clever, right? Changing your shirt or hairstyle make you look like somebody else. And then you're somebody else. That is great. I love that.
There's
Yeah.
also another situation in the chat box. Sometimes it's hard to divert a situation. I've dealt with a patient that became violent because of a call she received from family members. It was really hard to divert her. She was unreasonable to where police got involved and they got agitated with her and they wanted to arrest her. How do you deal with someone like that?
Yeah, I think you just have to back off and give them a lot of space. I'm not sure the police was going to help at all. In fact, it probably would make the situation worse, you know? But if they are acutely delirious and they do need medical attention, you know, it might be helpful to, you know, get them to the emergency room another way. But I'm not sure the police is the correct way. Maybe it's a transport ambulance, you know. But the police usually makes people, I mean, how would you like it if the police were carting you away? If you were paranoid, you'd be even more paranoid.
It's gonna be more paranoid if we call the police. I mean, you know, it's not, I don't think it's a good idea. It's better if you're gonna call the 911 like that and bring to the hospital
Yeah,
instead of calling a police.
right. Oh, she called the police herself. Yeah. Oh, okay. So you know what you do? Yeah. When the police comes, you know what? Police actually, you've seen that this happens a lot, right? They go to these care homes and nursing homes because these patients call 911, right? And then you have to sort of intervene and tell them and say, yeah, actually, you know, we actually need medical, and you know, see if we could change it that way. But if the police can come and if they're concerned and maybe even just listen to them, and sometimes all they need to do is listen to them and say, oh, okay, we'll look into it, you know, then that may at least help her kind of validate her feelings and concerns and then still try to get her the help that she needs. Anybody else had that?
There was another add to Miss Lolo's case. She becomes physically aggressive and hits caregivers when help is provided. Miss Lolo thinks she can do her toileting by herself, but at a very high risk for fall. What are your thoughts?
What if people tried? I know plenty of patients resist personal care.
Some comments are to notify the nurse, and in regards to the using a monitor, as long as it's care planned was a comment, and confirming with family that they don't mind using the monitor for their safety. That's a good comment, notifying the nurse also,
Yes.
or the doctor.
Okay, so just FYI, Department of Health, Office of Healthcare Assurance, you're required to actually have addendum to your policy, putting that you do have the camera, and you have to have signed permission from the family
Mhm.
to have a camera.
Thank you for that input.
Excellent.
So what do people do if they don't want help toileting when they really need help toileting? Anybody creative? Like I said, you have to be a ninja here. We talked about not doing something to somebody, but instead seeing if you could find a way to partner with them to do something with somebody. How would that approach change?
Well, you can ask them. I'm not sure how positive that's going to be.
Uh-huh.
Encourage them. Again, you know how you give them medication with ice cream. You can always say, oh yeah, it's time to go eat, but let's go to the bathroom first because we have to go wash our hands.
Exactly. That was what I was going to suggest, right? You say, oh, you know what? It's time to go eat. Do you smell the food? I wonder what's on the menu. It's your favorite thing? Let's check. Can you help me? We need to set the table together. We need to make sure the napkins are out. Maybe you can help me. Let's go wash our hands together. And then you walk with her and wash. And when she's washing her hands, you wash your hands, right? And then, you know, as you're talking and you distract her and talk about maybe the food that's expected or what does she want to eat? What is her favorite thing? And, you know, before you know it, you know, yeah. You can do things kind of just do them without, you know, like slide things along while you're talking. And then, you know, before you know it, it's done, right? Or you could find easier ways of doing things. So if she's having trouble, maybe instead of pants, right, she could just have a dress, right? Like a muumuu, something like that. That's very easy to, when she sits down, you can just, you know, very, very simple to slip off and stuff. Not like you have to do the whole undressing, unzipping, and all this and this and this, and so complicated. So, yeah, I mean, I have a patient I take care of who hates putting his shoes on, doesn't like to put shoes or slippers on or anything, but then he's going to be a falls risk, right? So every time they try to put it on, he kicks them because they grabbed his foot, and he kicks hard, and nobody wants to put shoes on him anymore, but then he can't walk without the shoes, right? And I saw them, they were still trying to hold his foot down, and he kept on kicking. That's, I could just see disaster, right? That's not the way to do it. So what do? We bought him special slippers like Crocs, or, you know, something that you could just slip on and you don't have to hold his foot or anything. You talk to him and have two people, somebody points to this and preoccupies him. The other one doesn't say a word, just slips on the slipper. That was the strategy, right? So that's what I'm saying, something like that, right? Or non-skid socks, right? Good. So maybe with the toileting thing, you gotta kind of do it like the sock thing, right? I mean, the shoe thing. You know, sometimes, you know, you have to think about it like kids too. Sometimes you want toddlers to do certain things. What do you have to do? Tempt them and coax them and make it funny, you know, make a joke, something, right? You have to be incredibly creative, right? I think the most creative people are caregivers who care for dementia patients. Because you got to think about, oh, how do I work around this one? right? You gotta be like the Kung Fu master. Any other thoughts?
I mean, if they are allowed to leave the facility, you can always say, oh yeah, your daughter's gonna be here in a little while to pick you up, so we have to go use the bathroom before she gets here. You know?
That's right. That's right. Right. Some people don't like showers, and that's another good way of doing it, right? So, oh, we're going to go out. Your daughter's going to come, or we're going to go out to see the doctor. We got to shower before you see the doctor, you know? And so you have to tie it immediately to something else. Or, oh, yes, and then when we go out, we're going to have ice cream. You know, that's the reward for finishing the shower or something, right? Yeah. And, you know, like I said, you know, one size doesn't fit all. And sometimes what worked today doesn't work next week. Right. So you got to have a bag of tricks. So I always say, you know, like Felix the cat had the bag of tricks. You got to have a bag of tricks. And if you don't have enough tricks in your bag, you got to talk to other people with different tricks. Right. But really, you have to change the approach. Make it very friendly, make it safe, non-threatening, so they don't feel like they're like the cat that has to scratch you to protect themselves, because you're safe. Yeah. Good.
That's why you have to really know your patient, because you need to know what make them tick. As far like well, if he likes, well, we try not to use food so much because that would be a no-no, especially if if the patient is diabetic. But like what you said, you know, you gotta have your bag of tricks. But if they love to do puzzles, or they love, you know, something that is tangible, you really have to know your patient, what he or she loves, because you can use that as a carrot, as a way, as a reward after completing the task. So whatever it is, whether to use the bathroom, the shower, or whatever it is, or maybe she likes the massage, or just the, you know, just the thing on the hair. Oh, you know, you can use that to entice again. So because she likes that or he likes that, you know, so that's the tricks that you have to do along in order for that patient to comply. Yeah.
Yeah. Most of the time, you're not going to have, you know, calling the police kind of level. Most of the time, it's going to be, oh, trying to give them a bath.
Yeah, that would be kind of threatening, isn't it? So that wouldn't work very well.
Yeah. So baths are actually very interesting too. I mean, I've had other creative things. They said, oh, let's give the dog a bath, because he loved animals. So they gave the dog a bath. And of course, he got all wet. He had to take a shower after that. But then they could talk about the dog during the shower. Right. So there's many, many ways you can be creative. Yeah. Okay, so anyway, the hour is up, and it was been fun to talk about. I hope it was helpful. And you know what? Think about it some more, because we're going to talk about it again next time. And we're going to talk about how to prevent these behaviors as much as possible, so we don't run into a crisis. So as you see in the chat box, there is a tiny URL thing. That's the evaluation form. So please click on that and start to complete the evaluation, and then you can get your certificate of attendance or continuing education credits. Thank you very much, and thank you for joining us. Really great to see you all.
Thank you. Thank you for your time.
Thank you.
Thank you, Doc.